Thank you, everyone, again for the opportunity to present some of the work that we've done in sub-Saharan Africa on Warfarin. Sorry, it's not responding. Oops. Yeah, so today I'll be talking about why Warfarin anticoagulation remains an area of unmet medical need why Warfarin anticoagulation remains an area of unmet medical need. Then I'll talk about why we need ethnic diversity in Warfarin pharmacogenomics. We've done some work on a clinical Warfarin dose initiation algorithm, which I'll describe briefly. We've also done some machine learning work. Then I will talk about some pharmacogenomic studies, which we have done before I conclude with work which is ongoing. So first, and mostly due to cost, Warfarin remains the anticoagulant of choice in sub-Saharan Africa. However, it has several dosing challenges. Specifically, it has a narrow therapeutic window. And the problem with that is if you give too much of it, then there is a high risk of bleeding. And if you give too little, there is a high chances of lack of efficacy. And then there is a wide interpatient dose requirement variability. Some patients require as low as 0.5 milligrams a day, while some patients may require more than 20 milligrams a day. And because of these challenges, the quality of anticoagulation in sub-Saharan Africa is quite low, with the time in therapeutic range ranging mostly between 28% and 52%. Unsurprisingly, it's the leading cause of preventable adverse drug reaction-related hospitalizations in South Africa. We've recently published some work on ethnic diversity, and it's currently recognized that we need ethnic diversity in pharmacogenomic studies. In this publication, we reported the number of pharmacogenomic studies that had developed using algorithms as of 20th May, and about 24%, that's 46 studies, had recruited at least 5% patients who identified as Black. If you look at the proportion of studies that included only Black patients, the number is quite low. So the few studies which have reported pharmacogenomic studies in African populations highlight the need for more work to be done in this region. We also did a systematic review on genetic factors influencing Warfarin dose in Black African patients, and out of 48 studies, only 2 were from South Africa. Unfortunately, these studies were all small-sized. On an individual level, there were similar effect sizes for important variants in CYP2C9 and VCOR-RC1. In terms of genome-wide association studies, only about 1% studies have included patients of African ancestry, and most of these studies are mostly from the US, as African Americans, who are not necessarily representative of sub-Saharan Africans. This 1% is quite low if you consider that Africans make up a big proportion of the global populations. Due to the few studies conducted in this region, we opened up a collaboration, that's Warfarin anticoagulation in sub-Saharan Africa. And among the initial aims, we developed a clinical Warfarin dose initiation algorithm, which has been published in CPT. The algorithm is shown here. So to use the algorithm, you start with the 20.28, then you subtract this multiplied by the age, and so on. And we round the weekly Warfarin dose to nearest 2.5 milligrams per week. The reason we do that is in sub-Saharan Africa, 1 milligram tablets are not readily available, and mostly the tablets are mostly available at 5 milligrams, which if you break into half, you get 2.5 milligrams. So we assessed this model using several performance metrics, and in the interest of time, I've only shown one risk of suboptimal anticoagulation, which was defined as an actual dose which was at least 40% lower or higher than the predicted dose. So with the fixed dose model, about 65% of patients would be optimally dosed, and this increases by 7.5% if you use the clinical algorithm. This was in the development cohort, which comprised 364 patients recruited from South Africa and Uganda. We validated it in a cohort of 690 black patients in the IWPC cohort, and in it, the benefits were even more pronounced. That is about 12% increase if you use the clinical dose initiation algorithm. Both increments were statistically significant if you look at the 95% confidence intervals. And based on this, we are evaluating this model for prospective utility. So when we were developing this model, we used simple linear regression techniques, and we wondered whether a more complex learning method would have done the trick. So we conducted a machine learning exercise in which we evaluated several machine learning techniques, including artificial neural networks, support vector regression, and random forest regression. We evaluated different performance metrics, but only the mean absolute error is shown here. And for development, we used the 364 patients, which I've talked about in the previous slide, and an external validation cohort, which was actually a temporal validation cohort. These were 270 patients who were recruited earlier after we had recruited these 364 patients. So in the validation cohort, random forest regression was the best performing model, but as you can see, it performed similarly to other simple regression techniques, including ordinary least squares regression, which is the most commonly used technique. Model trees stands out as the worst performing model, and that is because it performs automatic tuning. It performs automatic parameter tuning, which is likely suboptimal when it comes to correcting for overfitting. So based on this, current work which we are doing, we are using the simple regression techniques, but when we get more data, we'll go back to and see whether complex machine learning techniques can be more beneficial. We've conducted some pharmacogenomic studies, and first we wanted to see whether previously reported genetic variants can be replicated in our cohort. Because we had a relatively small sample size, that is 524 participants, we started with a pharmacokinetic approach, and the pharmacokinetic approach is more powerful than, say, using the stable Warfarin dose, because you directly measure the drug concentrations or metabolites, and you circumvent the issue of adherence. And as you can see, using for the S-Warfarin, R-Warfarin outcome, CYP2C9 star 8, star 9, and star 11, plus the CYP2C9 SNP gene cluster SNP RS1277823, passed the Bonferroni adjusted replication significance threshold. CYP2C9 star 6 didn't pass the threshold, but that is mostly attributable to the minor allele frequency, which is a bit low. From here, you can see that the common variants, star 2, star 3, and star 5 are missing. Star 2 and star 3 are common in whites and Asians, and star 2 was not included because it was not on the genotyping panel we used, and it could not be successfully imputed. It had a very low R squared, it is 22%. Star 3 and star 5 were successfully imputed, but the thresholds, the minor allele frequencies were below 1%, so they were also excluded. Also, and based on the minor allele frequency of CYP2C9 star 2 in the 1,000 genomes African populations, it's around 0.8%. Even if we had imputed it or genotyped it, it would still have excluded it based on the minor allele threshold. So what this slide shows is that the star 2 and star 3, which are common in whites and Asians, are less relative to African populations. And variants such as star 8 and star 11 are more important when you come to sub-Saharan Africans. So after replicating this, we are conducting several genome-wide association studies to identify novel variants. And again, because of sample size, we've started with a pharmacokinetic approach where we look at the plasma concentrations of S-Warfarin, of Warfarin and its metabolites. So we have looked at many outcomes. So I've only showed one, that is S-Warfarin and the S-Warfarin R-Warfarin outcome ratio. And you can see in chromosome 10, this is about 325 SNPs past the Warfarin adjusted significance threshold, and they include SNP 2C9*8. Of these SNPs, about 70% were in LD with this SNP with star 8, and then the RS1277823. You can note that there is no peak in chromosome 16, but because we are looking at the pharmacokinetics, you wouldn't expect a peak here because of course RC1 is involved in Warfarin pharmacodynamics. So our next step is to look at the stable Warfarin dose, which hopefully should cover both the pharmacokinetic and pharmacodynamic aspects. So what we're currently doing is we're doing a GWAS for stable Warfarin dose, and as I've said earlier, our current sample size is a bit small, so we are obtaining additional samples from collaborators. And we're also including patients of mixed ancestry using local ancestry-based methods like Tractor. After this, we'll plan to develop pharmacogenetic dosing algorithms to supplement the clinical dose institutional algorithm. Of course, one can argue that in sub-Saharan Africa, where resources are limited, the clinical dose algorithm is more important, but in the interest of diversity, we don't want sub-Saharan Africa to be left behind. And fortunately, the cost of genotyping is currently going down, and in our group, there's also a point of care assay, which is low cost and which we are trying to validate at the moment. There's also a possibility that Warfarin treatment in blacks is polygenic, so we are also planning to develop a polygenic dosing model, and Warfarin is being gradually replaced by direct oral anticoagulants, so we're also working on the pharmacogenomics of DOACs. So I'd like to thank my supervisors, our collaborators, and staff of the institute and patients from where we obtain data. And questions are welcome from you. Thank you.